My name is Aaron Armstrong. I'm an interventional cardiologist and the medical director of the Adventist Heart and Vascular Institute in St. Helena, California. Today, I'll be discussing intravascular lithotripsy for peripheral artery calcification, and I'll be presenting the updated results of the complete cohort of the Disrupt PAD3 observational study. Endovascular treatment for calcified PAD is a complex issue that makes procedures both more complex, time consuming, and increases the risk of both acute procedural failure and long term success. Prior to balloon expansion, the treatment of calcium can result in the resulting dissections as well as acute procedural failure. Stents, of course, have been developed to address balloon angioplasty failure, but they have the ability to fracture and may complicate future interventions. Other devices meant to target the treatment of calcium, including atherectomy, are available, but do have the potential for increased risk of procedural complications. For these reasons, moderate to severe calcification is often excluded from trials, resulting in a paucity of data to guide treatment in this challenging patient population. For all of those reasons, the Disrupt PAD3 observational study was developed, which is the largest to date ever study of calcified lesions in a prospective manner. And today I'll be presenting the full cohort analysis evaluating the procedural safety and effectiveness of IVL treatment in a real world, heavily calcified PAD cohort. The Disrupt PAD3 observational study is part of a spectrum of studies that Shockwave has developed to study the use of intravascular lithotripsy in multiple vascular beds. You can see here that this started with the Disrupt PAD1 study in the SFA and popliteal, the subsequent Disrupt PAD2 study, followed by the Disrupt BTK study of below knee lesions, and then the very important Disrupt PAD3 randomized trial in the SFA and popliteal arteries utilizing drug-coated balloons. And what I'll be presenting today is the Disrupt PAD3 observational study, which is a single-arm observational cohort study that includes the treatment of lesions in the iliac, common femoral, superficial femoral artery, popliteal artery, and below knee vessels. The study design of this, as I mentioned, was prospective. It was multi-center and single-blind. The objective was to assess real-world periprocedural outcomes of intravascular lithotripsy for the treatment of calcified stenotic peripheral arteries. The key inclusion criteria for this study included Rutherford classification 2 to 6, the presence of moderate to severe calcification, and that the lesion was in the iliofemoral, femoral, popliteal, or infrapopliteal arteries. This was an angiographic core lab adjudicated study that was conducted by the Yale Cardiovascular Research Group. And you can see here that in this very large multi-center study, a total of 1,373 patients were enrolled at 30 sites and a total of 1,677 lesions. Inclusion in this study involved the use of intravascular lithotripsy treatment and the potential use of adjunctive technology at the operator's discretion. From the core lab analysis perspective, 91.3% of these lesions were evaluable, leading to a total of 1,262 patients for full evaluation and 1,531 lesions for core lab assessment. So a few words about intravascular lithotripsy. You can see here in this video that intravascular lithotripsy involves the use of a balloon inflation followed by the delivery of lithotripsy pulses. Each pulse delivers an effective pressure of approximately 50 atmospheres to accommodate the different speeds of the pulses. There is a low balloon inflation pressure that's utilized, typically 2 to 4 atmospheres. And an important differentiating factor of this technology, because of its mechanism of action, is that it fractures both superficial and deep calcium preferentially while not injuring the non-calcified tissue. In this micro CT example seen here, you can appreciate how before the use of intravascular lithotripsy, there's essentially a sheet of dense calcium, and that application of intravascular lithotripsy leads to fracturing of these calcium sheets in a linear manner across the area of calcification. So here are the baseline characteristics of the observational cohort. Among the 1,262 patients available for evaluation, as you'd expect, over half of these patients had a history of diabetes. And importantly, almost a third of these patients had renal insufficiency. And because this was a real-world study, it also included a significant cohort of patients who were on dialysis as well, who again are typically excluded from most clinical studies. With regards to Rutherford classification, you can see that a little over half of the patients had severe disabling claudication, but importantly, over a third of the patients in the study had critical limb ischemia, including a subset of patients with Rutherford 6 critical limb ischemia. Here are the baseline lesion characteristics. Among the 1,531 lesions available for core lab assessment, you can see that approximately a third of these lesions were chronic occlusions. The lesion length was a mean of 94 millimeters, but importantly, 1 out of every 5 lesions treated was over 150 millimeters in length. With regards to the vessel beds that were treated, the SFA was the most frequent target vessel bed, but there was a high percentage of iliac, common femoral, popliteal, and below the knee lesions enrolled as well. With regards to procedural characteristics, you can see here that the use of embolic protection was 6% of the time overall, although the majority of the time this protection was used when an adjunctive technology such as other atherectomy was utilized. Predilation was performed in 30% of the cases, and some type of dilation after intravascular lithotripsy was performed 79% of the time. You can see here that 78% of the time, intravascular lithotripsy was the only calcium modifying therapy. And with regards to other adjunctive technologies that were utilized, you can see here that 8% of the time a specialty balloon was utilized, atherectomy was utilized 16% of the time. And with regards to definitive therapy, the most frequent additional therapy was the use of a drug-coated balloon, followed by the implantation of a stent about 1/3 of the time. So here are the acute angiographic outcomes. And again, these are core lab adjudicated. The baseline diameter stenosis pre-procedure was 81% on average. Post-intravascular lithotripsy, the mean stenosis was 33%, with a final end of procedure stenosis of 24%. Importantly, the rate of complications was very low. The rate of severe complications, grade D through F, was 2.2% post-IVL and only 0.7% at the end of the procedure. And the overall rates of any perforation or distal embolization or slow or no reflow were extremely low, both after intravascular lithotripsy and at the conclusion of the procedure. So I think overall there was a consistent reduction in diameter stenosis with very low rates of angiographic complications. So how do these results stack up compared to the previously reported results from the PAD-3 randomized study of the superficial femoral and popliteal artery? I think what is remarkable is the consistency of these results. You can see here that the baseline stenosis was similar between these two studies. Post-IVL, again, there was a very similar residual stenosis in the range of 27 to 33%. And in both of these studies, the final stenosis was under 30% on average and in the range of 22 to 24%. In addition, this was a much more real-world cohort involving multiple vascular beds and patients who might otherwise be excluded from a randomized trial. And you can see here that the rate of severe complications was also extremely low in the observational cohort. So I think this really provides some important evidence for consistency of outcomes with application of IVL to a real-world cohort and compares very favorably with the results that we saw in a randomized clinical trial. So, as I mentioned, different vessel beds were enrolled in this study based on the lesions that were calcified. And this just shows here the breakdown of where those lesions were in the iliac, common femoral, SFA, popliteal, or below knee. You can see here that on average, the lesions in the superficial femoral artery were longer than in other vessel beds, as to be expected. And I think consistent with the treatment patterns for these different vessel beds, you can see here that IVL only was actually used 94% of the time in the iliac without other adjunctive atherectomy or specialty balloons, whereas there was a higher use of atherectomy or specialty balloons, for example, in the common femoral artery and popliteal artery. With regards to definitive therapy, this again reflects some of the treatment of those vessel beds. As you'd expect, stents were used fairly frequently in the iliac, but were used much less frequently in the common femoral artery, superficial femoral artery, popliteal, or below knee regions. If we look at the outcomes across all those vessel beds, you'll again see a consistency with regards to the post-IVL stenosis. coming in at around 30% in each of these vessel beds, and the final stenosis being in the range of 21 to 24%. And importantly, the rate of severe complications of severe dissection, perforation, or embolization were consistent across each of these vessel beds and at very low rates, regardless of the vessel bed where intravascular lithotripsy was utilized. If we look at the adjunctive therapies that were utilized in complex lesions and complex patients, you can see here that, as I mentioned before, 19% of these lesions were over 150 millimeters, about 20% were eccentric, a third were chronic occlusions, and 62% had severe calcification. You can see here that depending on these lesion subtypes, if it was a very long lesion, it was a little more frequent that atherectomy or specialty balloon may have been utilized in addition to intravascular lithotripsy. But on average, between 1 out of 4 and 1 out of 5 cases, some type of adjunctive therapy was utilized. As you'd expect in these more complex lesions, it may have been more frequent to use drug-coated balloons, especially in long segment superficial femoral artery disease. And there was a little bit higher rate of stent use for more complex lesions, likely related to the complexity of the disease state itself. With regards to the outcomes in both complex lesions and complex patient types, you can see that post-intravascular lithotripsy, the residual stenosis was slightly higher on average, around 34 to 42%. But again, a very consistent reduction in the percent stenosis relative to the baseline. I think what is impressive here is that even when treating a chronic occlusion, which by definition was a 100% stenosis at baseline, there was only a 41% residual stenosis after intravascular lithotripsy and under 30% after final therapy. A few other important cohorts, I think, to consider with regards to the outcomes that are either historically understudied or which have had poorer outcomes in other studies include women, patients on dialysis, and patients with critical limb ischemia, each of whom represented an important subgroup within the observational cohort. You can see here that consistent with the overall study, intravascular lithotripsy was the only therapy utilized about 80% of the time. And then definitive therapy with either drug-coated balloon or stent was utilized with about 50% of the time, drug-coated balloon and a stent between 20 and 34% of the time. And then finally, with regards to the outcomes in those complex patient subgroups, I think what's striking here is that the mean percent stenosis after intravascular lithotripsy was very similar in each of these cohorts relative to the overall results, with a mean residual stenosis in women of 30% after IVL, 28% in dialysis patients, and 31% in patients with critical limb ischemia. And again, you can see here at the bottom, the rates of any severe complications, again, were very low in these very important and complex patient subgroups. So because this was a large cohort of patients and lesions that were enrolled, we were able to also conduct a multivariable analysis to look at predictors of residual stenosis less than 30% at the end of the procedure. As you would expect, some of the predictors of residual stenosis included a long lesion length. Interestingly, women were less likely on multivariable analysis to have significant residual stenosis compared to men, with an odds ratio of 1.85 for achieving a residual stenosis less than 30%. Patients who were less than 75 years old were more likely to achieve a low residual stenosis. And as you'd expect, patients with a chronic occlusion were less likely to achieve a less than 30% residual stenosis. Interestingly, however, and I think very important from a technique standpoint, the use of an intravascular lithotripsy balloon that was greater than 1.0 relative to the reference vessel diameter was a predictor of decreased residual stenosis. So the take-home point here, I think, is that utilizing an intravascular lithotripsy balloon that is slightly oversized relative to the reference vessel diameter is more likely to create a residual stenosis less than 30% without any increased risk of significant complications. With regards to angiographic complications, the main predictor of adverse outcomes was a lesion length over 150 millimeters. this did have a significant predictive effect on the risk of still having a residual stenosis greater than 30% at the end of the procedure, period. So the take-home message here, I think, is that proper intravascular lithotripsy balloon sizing is an independent predictor of stenosis reduction, and that should be utilized as part of the procedural planning, especially when performing intravascular lithotripsy on some of these more complex lesions. In conclusion, this analysis from the Disrupt PAD3 observational study is the largest core lab adjudicated real world evidence to date for heavily calcified peripheral artery disease. This study included 1,531 heavily calcified peripheral artery lesions with angiographic core lab assessment. The study included complex patients, including patients with critical limb ischemia or those on dialysis, as well as complex lesions, including a high percentage of chronic occlusions and very long lesion subsets. The procedural safety and effectiveness with intravascular lithotripsy were excellent in this challenging patient and lesion population. There were no distal emboli, abrupt closure, slow flow, no reflow, or thrombus at final core lab assessment. And I think an important takeaway is that there were very consistent outcomes with intravascular lithotripsy compared to the intravascular lithotripsy arm of the Disrupt PAD3 randomized trial. And the use of adjunctive technology was at the operator's discretion, and it demonstrated complementary use with intravascular lithotripsy based on decision making at the time of the procedure. And then finally, as I presented, multivariable analysis demonstrated that appropriate sizing of the intravascular lithotripsy balloon, slightly bigger than 1:1, is an independent predictor of improved stenosis reduction without an increased risk of angiographic complications. I think that the Disrupt PAD3 observational study provides a number of important takeaway points for the treatment of patients with severely calcified lesions. This study, which enrolled over 1,500 lesions, demonstrated in multiple vascular beds, including the iliac, common femoral, superficial femoral, popliteal, and below knee arteries, that intravascular lithotripsy has a consistent reduction in post-IVL stenosis in the range of 25 to 30%, final stenosis post-IVL, with very low rates of any severe complications. Because this was a very large study, we were able to look at important subgroups, including complex patients such as those on dialysis or with critical limb ischemia, as well as complex lesion types, including very long lesions or CTOs. And each of these sub-analyses demonstrated a consistent reduction in stenosis. On multivariable analysis, I think a key takeaway is that the use of an IVL balloon sized slightly larger than the reference vessel diameter was actually an independent multivariable predictor of a stenosis less than 30% after intravascular lithotripsy. So from a procedural standpoint, I think a takeaway here is to slightly oversize the intravascular lithotripsy balloon, for example, 0.5 millimeter larger than the reference vessel diameter, and that's going to get you a better angiographic result acutely without any increased risk of procedural complications. I think a very important aspect of the Disrupt PAD3 observational study is that it was an all-comers cohort. So it included the types of patients that we frequently treat on a regular basis, but whom are otherwise excluded from randomized trials. For example, there were a significant proportion of patients enrolled in this study who were on dialysis. There were also a number of patients enrolled who had critical limb ischemia, including Rutherford class 6 critical limb ischemia. So the results of this study and the subgroup analyses, I think, lend very important data to these difficult to treat complex patients for whom we really lack any significant data in any kind of a core lab adjudicated fashion, because these are the highest risk patients who have severe calcification and other comorbid conditions. I think with regards to these results, one thing that was frankly surprising is that because this is an all-comers cohort, the rates of any severe complications were extremely low, with very low rates of severe dissection and essentially no perforations or distal embolization or slow flow. I think this really speaks to the safety of intravascular lithotripsy and that you can apply intravascular lithotripsy in some of the most difficult to treat patients and be confident that the rate of any severe complication is going to be extremely low. I think these results will influence my practice moving forward in two ways. First off, knowing that we have data in complex patients, such as those on dialysis or with critical limb ischemia, gives me the confidence to utilize intravascular lithotripsy for these complex patients and know that I can do it safely and achieve a good diameter stenosis reduction as well with intravascular lithotripsy. Second, I think that the take home point from the multivariable analysis that slight oversizing of the intravascular lithotripsy balloon results in better post IVL stenosis and no increased risk of complications is an important takeaway from a clinical standpoint.